Good afternoon, everybody, and welcome to our next presentation. Our presenter is no stranger to the facial pain world. It's Dr. Jeffrey Brown, who's the chair of the Medical Advisory Board here at the Facial Pain Association. He is um, the neurosurgery director of the CyberKnife program at NYU Langone, Long Island, and his favorite expression when he's around a patient is "I can help you," which is just wonderful to hear. So, without any further ado, I want Jeffrey Brown to start. And please put your questions in the chat, and we'll save plenty of time for questions afterwards. Okay, to you, Doc.
Thank you very much, Anne, and thank you, Allison, for putting this all together. I do want to say that I think Dr. Leakey knows more than 99.9% of the world in how to treat aspects of facial pain, and that presentation from Dr. Leakey should be required reading of every physician that you as a patient see. It's a heck of a thing to take on yourself, but we as physicians need to hear what he has to say. So I know the discussion about trigeminal neuralgia, whether it's trigeminal neuralgia or something else, has gotten quite complicated. So I don't use the term trigeminal neuralgia. I try to think simply. I don't use the words typical or atypical. I try to talk in my own language, speaking of communication, in terms of trigeminal nerve pain. Do you have trigeminal nerve generated pain? Is it neuropathic? To talk a little bit back to basic medical issues, there's two main types of pain. There's neuropathic and nociceptive. I got to talk medicalese a little bit. Nociceptive pain is when you cut your finger and the nerve sensors pick it up as some form of inflammatory response and it hurts. That's nociceptive pain, and that's treated with traditional medicines, anti-inflammatories, even opioids. Neuropathic pain is generated by the nerve itself. And so the question I as a neurosurgeon want to know is this a pain that comes from the nerve? And if so, maybe I can help. I'm talking that I'm simplifying things, and Dr. Ansari, if you were listening, said, well, you know trigeminal neuralgia because the person just talks to you and says something and you know they have it. But it's not that simple. I use a questionnaire. It's one page. It seems long. It's called the McGill Pain Questionnaire. And I ask my patients, before I ask them questions, to fill it out. They use one word in each of those boxes to see if it fits the description of their pain. And as it turns out, facial pain is not purely one thing. Even in patients who I would say have, quote, classical trigeminal neuralgia, and again, I don't like that term, it's more complicated than I have one kind of pain. The textbook description is lancinating pain. Well, no patient ever says, you know, I have lancinating pain. That's not the way it works. How does it work? They may have what are called paresthesias, meaning electrical sensations, or they may have these other sensations. Sometimes the words are hard for them to come up with. Those are called dysesthesias. It's a silly name because all it means is it's an odd feeling. So patients may say, in order of severity, that their pain is jumping, flashing, or shooting. We know about shooting, but they may not use the word shooting. It could be one that's a little bit less. Is it pricking, boring, drilling, stabbing, lancinating? Those are progressively more severe elements of the same electrical element. Is it sharp, cutting, or lacerating? Those are all elements of nerve-generated pain. Also, the pain may be intermittent. In that case, very rarely will someone they have constant shooting pain. It's hard to even survive if that's true. There are these more constant elements to the pain: hot, burning, scalding, searing in order of severity. Tingling, itchy, smarty, stinging. Those are still part of the nerve-generated pain that's trigeminal neuropathic. Now, at the same time, these kinds of pains can generate other pains, which are traditionally the kind of pain you get from tissue injury. Dull, sore, hurting, aching, heavy. Those are pains from, say, a tooth pain. Pinching, pressing, gnawing, cramping, crushing. Those are all what are called the nociceptive or inflammatory pains, but they can be mixed in. So on the right is one of these questionnaires of a patient whom I treated for what might be called simply trigeminal neuralgia, but look at all these different words that they used to describe it. They used flickering, but they also said jumping and stabbing and sharp, but then they also said it was crushing and pulling, and then it had a constant element, burning and tingling. It's mixed in. It's not as simple just to say, I talked to the patient and they told me what they had and I knew it. I didn't need to look into it any further. So this questionnaire helps me in understanding whether the pain is predominantly the intermittent stabbing, or it's predominantly constant in tingling or burning or prickling, or it's a mixture with other kinds of these nociceptive pains. But you can have that and still have something where I use the word, as Anne said, I can help you as a neurosurgeon. So when it's appropriate to seek help from someone like me, from what we would call, I would call, immodestly again, an expert neurosurgeon. I say, and I may be biased, as soon as someone is considering the diagnosis of trigeminal nerve pain, why not talk to an expert neurosurgeon? I'll talk in a second about what constitutes such a person, not just me. Trigeminal nerve pain is a rare entity. So there are few people like Dr. Liedtke or like Dr. Nitzdorf or like Dr. Ansari who could be considered experts. Many people are competent, but are they experts? But neurosurgeons, such as members of my medical advisory board, do treat this a lot. Now, this slide is an example of one neurosurgeon, and on his website, he or she listed everything that they're, quote, an expert at. And my red lines say an expert in everything is a generalist. So if it's just one spot in a list of many, many problems, trigeminal neuralgia is in there, does that make them an expert? Maybe not. An expert has a combination of emotional expertise and technical expertise. We all know about the grumpy doctor who says he's the best in the world, but he can't talk to you in any human way. That's not an expert. He needs to, or she needs to, exhibit professionalism, which includes emotional expertise. Now, you won't know that looking at a website. You have to meet that doctor and see if you're comfortable with that individual. It requires a form of integrity. Is it a person who contacts you by looking at you in your eye? Is it a person who shows the elements of compassion? He can reflect on your often emotional statements and observations. He can listen to you without interrupting. He can summarize at the end of his evaluation, I'm going to use the word his, and give you a plan, something positive, not, I don't know what this is, and if I don't know what this is, then nobody knows what this is. But if he doesn't know what this is, he knows his limitations, is he caring enough to say, you know, I don't know how to treat this, but I do know, or I can help you find someone who does. That's emotional expertise. What makes an expert in what I'm going to talk about in a minute? Microvascular decompression. So again, competency versus expertise. A paper was done a number of years ago on technical expertise. And it discovered, by careful review of patients around the United States who had microvascular decompression, that if a neurosurgeon has done at least 29 microvascular decompressions every year, there are fewer complications, especially if it's done at a hospital that does at least 20 microvascular decompressions per year. Why is that? Because we do not work alone as surgeons. We must have a team. We must have an operating room that knows how to take care of the surgeon during the surgery. We must have an intensive care unit that knows how to take care of you after the surgery and deal with any complications immediately. Immediately, not stall. That's what makes a difference. Everybody has some complication as a surgeon. An expert is not perfect. An expert is someone who does the best job one can think of. When do you really consider surgery now? Now, my way of thinking is when medication has failed. Everybody starts with medication. What are my criteria? When, I'll read it, when properly titrated doses, and they have to be properly titrated, given at the right dose, of at least 2 of the seizure drugs cause poorly tolerated cognitive side effects, but they don't reduce the pain, then one can consider a surgical option under certain conditions. Except for what Dr. Liedtke says, it's not, in my experience, good to do multiple drugs unless you have a Dr. Liedtke to do it. And I don't know about facial creams, but Dr. Liedtke does. A little bit of basic physiology. The trigeminal nerve pain that's nerve generated is a result, we think, by hypothesis, of a short circuit in the nerve, the trigeminal nerve root, not the part of the nerve in the face, but in the level of the brainstem, inside the skull. And after years of discussion, it's generally accepted that it's no longer a hypothesis, but an accepted theory, that neurovascular compression, an artery or a vein that day after day, hour after hour, year after year sometimes, pounds against the susceptible part of this nerve root up against the brainstem, that it begins to strip the insulation that's on every single fiber, and there are thousands and thousands of those fibers in the cable that constitutes the trigeminal nerve. It's a cable, it has an outer covering, but inside it are thousands of wires, many of which have their own insulation. Some of which don't have any insulation, but they're not the problems. When the insulation is stripped and someone touches your face, sensation goes through the nerve, and if adjacent fibers have their insulation stripped, you get a short circuit, which is why these seizure drugs are being talked about. Because what does a seizure drug do? It slows down the electrical conduction in the brain, in the nerve, in the spinal cord, everywhere in your body, in order to get to just that one little area where you're getting the stabs, which are a result of the short circuit. Patients with multiple sclerosis get short circuits for a different reason, because of injury to the myelin from the sclerotic disease. That's a little bit different, but that's the main difference. And I'll talk about brain tumors also in a second, because I don't think that's really different. By the way, that's why trigeminal nerve pain can come and go over a period of time because this insulation can heal, or it tries to heal. And when it does, maybe the pain stops. But because this artery or vein keeps pounding and pounding and pounding, the insulation breaks down again and the pain starts up again. So this is an image in a cadaver of what it looks like within the skull. This is the edge of the bone, and this is within the skull. To the right, I don't know if you're seeing my pointer, is the trigeminal ganglion. And if we're going to see where the injury is, it's from this artery called the superior cerebellar artery, which is a normal artery that just happens to be lying up against the sensory part, which is susceptible to injury of the trigeminal nerve. Now, just because that artery is there does not mean you have trigeminal neuralgia or you will ever get it. The issue is if you have it, meaning intermittent nerve-generated pains or constant nerve-generated pain, and you see on an image, we'll talk about how to get that image, that the artery is there, then maybe you have a chance of getting rid of this problem by moving that vessel off of the nerve. So that's the contact point. Again, it's not an abnormal artery. It's not an abnormal nerve. It just happens that the two of them get together in a way that causes this symptom. In a little more anatomy, there are other nerves that are nearby. I know Dr. Ansari talked about trochlear nerve pain. I don't know about that, but this is the fourth cranial nerve, which is nearby. Neurosurgeons need to know that it's nearby, and I'll get to why. And here is, I keep doing that. Here is the facial nerve. And let me clarify, the trigeminal nerve is not the facial nerve. The facial nerve moves the muscles of your face. The trigeminal nerve does move some muscles in your face. It moves the chewing muscles, but it doesn't move the smiling muscles or open and close your eyes. That's this seventh nerve. And they are right in this area, and they're important to keep track of, and I'll talk about that. Again, the face is out to the right. This is the ganglion. The problem's not in the ganglion. Treating the ganglion isn't going to do it. It's this part, which is the root or the trunk of the nerve as it enters the brainstem. I'm sorry about the medicalese. It can be a vein. This is the fifth nerve, and a vein can cause the problem as well as an artery.
Dr. Brown, are your slides advancing?
Uh-oh. They're not for you?
Well, they're not for some people.
Are they for you? Because they are for me. You want me to reload here?
I think. Yes, please.
Okay. Are you seeing them now?
Yes. We were seeing them, they just weren't moving along.
Okay. So let's do maybe some people's, never mind. So Dr. Ansari mentioned, if you heard his talk, you don't need an MRI for the diagnosis. You don't need the diagnosis. The diagnosis of trigeminal neuralgia, trigeminal nerve pain, is not made by an MRI. But if you have the appropriate symptoms, then an MRI is very helpful. Why? Because it can tell you about a possible way to get rid of the pain. Remember, medicine can help you with the pain, but the medicines are not antibiotics. They won't cure the problem. They don't make this myelin heal. They just slow the electrical conduction enough so you don't get the short circuiting. Neurosurgery can get rid of the cause, which is an artery or vein on the nerve. So an MRI is helpful for two reasons. Yes, it can show a tumor, but that's not very often. And this MRI has to be done in a special way. So if you go to your family doctor and he says you have trigeminal neuralgia and you say, I need an MRI, and he orders an MRI, that's not necessarily going to be helpful. Yes, it would show a brain tumor in 1% of patients, but it won't show this relationship of the nerve to the artery, which can be helped by me as a neurosurgeon. This is a side view. This is a straight ahead view. And this is a view from underneath. So if you look straight ahead at the brainstem, this is the trigeminal nerve, and this line here is the artery pounding against the nerve. It doesn't look big, but it's enough. This is the nerve on a side view with the face out here, and this is the artery coming on top of the nerve. On the cross section, the nose and the eyes are up here. This is the nerve, this is the brainstem, and this thing is that artery. And that tells me as a neurosurgeon that if you have nerve-generated pain, maybe I can help you with a surgery. So all MRIs are not created equal. If your doctor says, we're going to give you the powerful MRI, the higher number Tesla, that doesn't do it. It's the software that's used to do the MRI. It has to have certain software that's called Fiesta or CISS or VIBE, and it has to have an intelligent radiologist, neuroradiologist, to look at it to know what they're looking for, because commonly the radiologist will say, well, the nerve is normal. Well, yes, the nerve does appear to be normal, but he's not seeing the artery that's bumping into it, or he's not thinking that that artery is a problem. It requires someone experienced in the review, which is why you may go to a neurosurgeon who say, well, I see your problem. And then you say, well, why didn't anyone else see it? Well, they didn't have the eyes that were focused on it in the right way. A word about brain tumors. Brain tumors can cause trigeminal nerve pain, but the way, in my understanding, the brain tumor causes it, this white thing is a benign brain tumor. It's hard to see, but what this benign brain tumor is doing is pushing this little white thing, which is an artery, up against something it's hard to see, which is the trigeminal nerve. So the way the brain tumor causes trigeminal nerve pain is by pushing an artery or a vein against the nerve. The problem is, if you then say, well, treat my brain tumor, that doesn't necessarily treat the trigeminal nerve pain unless you take the artery or vein off the nerve. So it's a two-part problem. Often people will say, well, it's real easy. I'll do Gamma knife and that will shrink the tumor. Well, it doesn't actually shrink the tumor. It stops it from growing, and you still have the problem with the artery pounding against the nerve, causing trigeminal nerve pain. So you got to treat the nerve. It may be okay to treat the brain tumor at the same time, but you still got to treat the nerve to deal with it. A word on glossopharyngeal neuralgia. The glossopharyngeal nerve is the nerve that gives you sensation in your throat and somewhat in your ear. This is an MRI scan that shows a little bit of a line here. That's the glossopharyngeal nerve. And then there's this thing here, which is another artery, which is called the anterior inferior cerebellar artery, that's bumping against the glossopharyngeal nerve. And that causes discomfort or even stabbing in the throat. And that's going to be treated potentially the same way we treat trigeminal nerve pain with this thing called a microvascular decompression. But you got to know to look for it. And most MRIs don't look for it. So again, it's a kind of expert-driven arrangement. Principles of surgery. There's two ways we do neurosurgery. One injures the nerve at the level of the nerve root, and the other decompresses the nerve. They both work. for different reasons, but they both work for different durations. Each of them is okay depending upon what's appropriate for you, the patient. What you're looking at is a picture, and you'll see it from other neurosurgeons, where the eyes are out there at the top of the screen. This on the left is the trigeminal nerve, and there's this artery stuck to the top and a vein bouncing up against this part of the nerve, which is the motor root, which is the nerve that moves the muscles of your chewing. And believe it or not, I don't quite understand it, but there are sensory elements to that, and that causes pain as well. But right next to it is a very important nerve, the facial nerve, which is important when I get to describing what needs to be done appropriately if you were to have this surgery. So what are these? They're called ablative procedures, operations that can injure the nerve root. They have different names. Radiofrequency thermal rhizotomy, it's done with a needle. Balloon compression rhizotomy, it's done with a needle and a balloon. We'll talk about it later on. It's done with glycerol, which is a kind of alcohol that's injected around the nerve root. And then there's the gamma knife, which is a fixed radiation source that's focused precisely on the nerve root, or cyberknife, which is a mobile radiation source that shoots many different beams of radiation precisely at the nerve root. And then there's a thing called LINAC, which is a modified version of the cyberknife, which isn't used so much anymore, but it also can be used. That's a very rapid way of going through these. Let me just bounce back. The radiofrequency thermal rhizotomy selectively heats parts of the nerve. The balloon selectively squeezes parts of the nerve to injure. Well, wait a minute. We're injuring the myelin. I thought you said that's already injured, and that's what's causing the pain. But note, if you reduce the amount of electricity that gets to the area where there's a short circuit, you can turn off the switch that causes the electrical shots. And that's what all these procedures do. They turn off the switch by reducing just a little bit the amount of electricity that gets to the short circuit. Not completely. We don't want to injure the nerve completely, because if you cause complete numbness, numbness is not an absence of pain, it's another sensation, which in itself is painful. That's this thing called anesthesia dolorosa. It means it's numb, but it hurts. We don't want that. We want mild numbness, which is okay. A little bit is tolerated, a lot is not. And that's all part of what is called the practice and art of neurosurgery. And that's where you get into an expert, because they need to know what's good and what's too much. The thing about these forms of ablative surgery is if you follow a patient that's had this for an appropriate reason, 9 out of 10 of them will be pain-free the day after surgery. And if you then follow them year after year, it turns out within 5 years, half of them will get their pain back. That's just the way it is, because we make a mild injury in the nerve, and the nerve can heal. That's a good thing. If the nerve heals, the bad thing is the pain can come back, because you're injuring the nerve in an area in front of where there's short circuits where the nerve is sensitive. And if the normal electricity gets to that short circuit, then the pain starts coming back. So, okay, it's possible to do this again, but there's a 50% chance the pain will come back in 3 to 5 years, and you'll have to do anything about it. If we go to the root of the problem and take that artery or vein off of the nerve, then those curves look much shallower, so that in the first 3 to 5 years, yes, some of the pain for various reasons may come back, but it's only about 5 or 10% of the patients whose pain comes back. And when you get out to 15 or 20 years, it's only 15 of the 90% of patients who've been pain-free on day one whose pain comes back. Yes, we hear about these patients because these are the patients that have more problems, but what we're saying is 75% of the patients who are pain-free on the first day after surgery will still be pain-free 15 or 20 years later from the microvascular decompression, because we've gone to the source of the problem, that darn artery or vein, and either moved it off the nerve, which you can do with an artery, but you can't cut an artery, you'll cause a stroke, or the vein has been coagulated and cut or moved off. Veins can be cut, arteries cannot be. You can do without a vein, though I say never take a vein before it's time, because if you cut one, others may form. So it's not my first line choice of activity, but it can be done. So this is a little scientific, but I guess if you see it, you'll understand it. So this is a cross-section, artistically drawn, of a trigeminal nerve, where right at this spot, the artery was bouncing against it. And the neurosurgeon who did this study not only decompressed it, but he had the courage, whatever, to take a biopsy of the nerve underneath the site of compression. We don't do this anymore because this is what's been found. This is what the normal looking myelin of a normal nerve looks like. It's this regular rounded thing around the center of this, which is a nerve fiber. This is the myelin, this is the nerve fiber. Keep an eye on this thing, which is a non-myelinated fiber, which we normally call pain fibers. I'm going to confuse you in a minute about that. These fibers, which have myelin, are not considered to be pain fibers. They're fibers that give you normal sensation. This is a pain fiber. But these are the problems, the ones that give you normal sensation. And why is that? Because if we touch your face and electricity goes through it, and this insulation has been injured, then you get the short circuits. It's from these normal non-pain fibers where you get trigeminal nerve pain. It's counterintuitive, I know, because these are cross-sections, they're electron micrographs of the injured trigeminal nerve underneath that artery. And all I can say is this nice little pattern isn't there. It's disrupted. It's a mess. The myelin has been repeatedly injured hour after hour, year after year, for God knows how long, till the myelin can't reform and the patient has constant pain or repeated stabbing pain. You don't want that. So let me explain again in this cadaver study. This is a real human. This is where the problem is at the arrow, and it's this part of the nerve that's injured. Well, this isn't, pretend this is the balloon squeezing the nerve. It's in front of the short circuit. Now you might ask, as you're thinking, why not just do that in the face? Why go all the way up to the brain to do it? Because this isn't so selective, this arterial compression, that it's only the nerve branch that goes to the jaw. You may think you only have pain in the jaw, but this is kind of mixed in. So if you injure the nerve to the jaw, say way outside of the skull, the pain has a way of leaking around to other parts of the nerve to get into the cheek. It's not so specific. But if you injure the nerve here, you have a greater chance of capturing the areas of the short circuit. This is a study that I did. This is not a human, but it's a rabbit who had not trigeminal neuralgia, but he had a radiofrequency thermal rhizotomy. The nerve right at the edge of the ganglion here was heated. So this is non-selective. There's just a hole in the nerve right there is what you're seeing. This is a study that shows myelin, insulation. The blue is all insulation. And radiofrequency is not selective to any fibers. It just injures the nerve enough to reduce sensation so that the short circuit part doesn't create the trigeminal nerve pain. A little bit more science. It's my science, so let me talk about it. This is an animal, a rabbit again, 3 months after having balloon compression. He didn't have trigeminal neuralgia, but he had balloon compression. And this is a cross-section of the animal's nerve with the myelin stain. All that's blue insulation, normal insulation, except it's mildly injured right there where the balloon squeezed it. And what's interesting is if you look at this with an electron microscope, I'm sorry for the science, but it helps to understand this. The red arrow points to these little bitty fibers. The little bitty fibers don't have any myelin around it. It's this stuff. These are pain fibers. So the counterintuitive thing about trigeminal nerve pain is it's not caused by pain fibers. It's caused by normal fibers that pick up normal sensation that get short circuits. The good thing is these can heal. The bad thing is when they heal, the pain comes back, which is why there's a high incidence of recurrence when any appropriate treatment is done with a needle. Yes, it's nice to be able to do what are outpatient procedures. All these operations that are done with needles are done, they take an hour to do or two, and you're out of the hospital 4 hours later. Is it safer? Not necessarily. Is it simpler? Maybe, but then you have to do the simple thing over and over during the course of a lifetime as opposed to getting it done once correctly. I hope you can see this video because this is what trigeminal neuralgia looks like inside the brain. Those are the arteries that are bouncing up against the trigeminal nerve and distorting it, and therefore causing the trigeminal nerve pain. And if they're moved off and kept off with a tiny pillow of this stuff that's Teflon, which is a form of insulation that the body doesn't react to, it stops the injury to the nerve from continuing. Okay. This gives me time to talk about the principles of if you're going to have microvascular decompression, this is how I think it should go. There's a period before, during, and after surgery. So before surgery, this surgeon who you choose should be someone who can discuss his personal experience, the complications that can occur, the complications that he's had occur, his expectation of the incidence that you'll get better, the risks of other treatments that might be done, and the risk of not going through surgery. All of those elements are important. It's not on a piece of paper that you sign 10 minutes before your surgery. It's a process of informed consent that has to be done by the surgeon. He has to take the time to go through this. It might take several visits. It's not a quick thing, but it lets you make an informed decision about whether to go through brain surgery. Oh my gosh. Then the second stage, if you choose to go ahead, you got to understand how it's going to work. What has to be done before surgery, what has to be done on the day of surgery, and what needs to be done after the surgery in the hospital and when you get home. By the way, if I can't show you on this MRI that there's an artery or a vein and there it is, and that's what I'm going to operate on, then I shouldn't be doing surgery, because with modern imaging, I believe, all right, I believe that almost always I can tell that there's something I need to go after, and there are no mysteries. You'll hear from Dr. Linsky later on about repeat microvascular decompression, which is a little bit more difficult to figure out whether there's something affecting the nerve, but even I will not operate again on someone whose pain came back after a microvascular decompression if I can't see that there's something on that nerve that I need to move off. That takes a neuroradiologist, such as the one that I work with, repeatedly, who can carefully evaluate these things, and it has to be done in what I call 3 planes. This way, and this way, all at once, because it's hard to interpret. But I won't explore the trigeminal nerve. That's a thing from the distant past with modern equipment and ability to do imaging. I don't do exploratory neurosurgery. You don't want exploratory neurosurgery, not in your brain. Now, during the surgery, what things need to be there? There's, first of all, there's a form of intraoperative monitoring. In addition to the surgeon, in addition to the anesthesiologist, we need someone else, kind of like a navigator with a co-pilot in the operating room, that is monitoring the function of the nerves in a way that I can't. There are things called auditory brainstem evoked potentials. I'll talk about them. There are facial nerve monitoring forms, trigeminal nerve monitoring forms, and monitoring forms of the brainstem, because moving an artery could, though it's only less than 1% risk, cause a stroke. Touching, pushing, moving the trigeminal nerve could injure it, and we can monitor the function of the motor part of the nerve to see if it's being irritated by the surgeon, so he stops. The same with the facial nerve, which also has within it the auditory nerve, but the facial nerve can be injured by the surgeon too, and if you push on it too much, touch it, stretch it, it will cause activity in the muscles of the face, and that can be monitored. So it's complicated, this slide, but we can actually monitor by putting clickers in the ears and electrodes in the scalp the speed at which the brain hears the clicker in the ear. And there's a certain big waveform, this one, which is the 5th waveform, which can be seen on the screen of a PhD who's monitoring in the operating room with a neurologist connected to the computer who may or may not be in the operating room, constantly looking at this wave. And if it begins to go farther out, it means it's taking longer for the brain to hear the click, which means that the nerve is being stretched. And if you do it long enough, you can lead to this, where it's not hearing anything anymore and the nerve has been injured. So if we're at this point where you see there's a delay in this wave appearing, then the physiologist will tell me, the surgeon, there is a delay and I have to stop what I'm doing and listen to them until that wave comes back to normal.
Dr. Brown, we have quite a few questions.
I'm at the end, like
Okay.
Dr. Leachy.
Do you
So
want to wrap up and then I'll ask them?
I'm going to give you 2 more slides and finish.
Okay.
There's this equipment for neuronavigation. It helps the surgeon plan the incision. There's this equipment that goes with it. There's a specialized intensive care that you need. I want to say that I do not use an endoscope. There's no proven benefit from it. I do want to say that studies have shown that the best quality of life after any form of surgery, ablative or microvascular decompression, is if the pain is gone with the microvascular decompression. And the best treatment is the one that's best for you based upon your pain your physical, emotional health, and the road to it is not dependent upon your age. So find your own way and your own path. Thank you, and I'm on to you with your questions, Ann.
Okay, thank you. The first one I have is about some red flags after you recover from an MVD. What are some things after you get home that you should be really alerted to? Like if something happens, when should you get back to your doctor?
The most common two problems I've seen is fever and tenderness in the incision, and that means that there's an infection underneath the skin.
Mhm.
Rarely is it in the brain itself.
And what about a cerebral spinal fluid leak? Uh-oh. We're going to wait for Dr. Brown to get back. He has just disappeared. Oh, here you
There.
are. You
There you
disappeared
are.
for a minute.
Rarely, only once in 40 years has there been an infection of the brain. That would cause severe, unrelenting headache. But mostly, if you're going to get an infection, which is still rare, it's in the scalp. And so a fever and redness or a fluid leaking from the incision, which means there's spinal fluid that's leaking. And that's not necessarily a slam bang emergency, either of them, but they need to be attended to.
Okay. And can you say something about surgery for occipital neuralgia?
Occipital neuralgia and trigeminal neuralgia can often be seen in the same patient because occipital nerve and the trigeminal nerve both intersect in the brainstem and they can interact. So it is possible that patients can have occipital neuralgia, which is pain in the back of the ear and the back of the head, and trigeminal neuralgia in their face. They're from different problems. They may have different solutions. Treating one may not treat the other, but it may. And so it's become more obvious that that's a real problem that needs to be adjudicated as to what is the best way to go about treating it. That's a whole nother lecture.
Okay. And we have another question. If someone has an MRI, a good MRI, that doesn't show a compression, but they are still in pain, is there a period of time after which you should repeat the MRI to see if a compression has formed or it's more visible?
Depends upon my personal review with my neuroradiologist of what constitutes, quote, a good MRI.
Okay.
It doesn't necessarily mean that I need to have the MRI done at my institution, but if the MRI doesn't allow me to look at the images in three planes, this way, and this way simultaneously, and take a little cursor and wander through the trigeminal nerve on every millimeter, then it's not, to me, a good MRI. So a good MRI is quite personal. And yes, very often I will repeat the MRI. But if I do that and I still don't see what I consider a source of vascular compression or contact, then I'm not going to go exploring, say, well, maybe it's there. I don't do that.
Okay. Right. No exploratory brain surgery. One other question. Some people have had an MVD that's been successful for years, maybe even decades, and then their pain comes back. What's happened?
So the first thing I would do after they've gotten medicine and the pain is under control is do a repeat MRI. So it's possible that in the first MVD, something was pushed away, perhaps a vein was cut, but a new vein formed, and after many years, that vein pounded away and caused the trigeminal neuralgia to reoccur. So I would look for a new vein. It's possible that an artery was pushed away, but there's a little part of it that's still in contact with the nerve, and after years, it's starting to cause problem. So the MRI will help me to know the answer. I do not think, in my experience, that the onset of trigeminal neuralgia is the first sign of the development of multiple sclerosis. However, I have not seen that.
Okay.
An MRI will tell you
Mhm.
pretty much if you have it, but I don't see that the first thing you should think of is, do I have multiple sclerosis? It's not true in my experience.
Okay.
Of course, there are many, many other causes of facial pain, as you all have heard, and we need to make sure that you have trigeminal nerve generated pain that's now developing, not something else.
Okay. And we have someone asking, if you go slowly and have an ablative procedure first, because you don't want brain surgery, is it possible to get an MVD after that?
Yes.
And can you also talk about what, neurolysis, combing the nerve? What does that do?
It's come into practice on patients in whom the neurosurgeon believes that either the vascular contact was not there when they went in to do surgery, and therefore what they do is kind of split the fibers of the nerves linearly, thinking that just by injuring the nerve a little bit, that will get rid of the pain, and it does. But my experience is if you didn't see, if you saw the compression, this is personal, if you saw the contact on the MRI, then it's there. You don't need to do anything else except decompress it. You shouldn't be operating if you don't see a vascular contact. So I don't go in to comb the nerve. I do a percutaneous procedure if I think there's nothing there. So I don't comb personally, but it's come into practice that the neurosurgeon will say, well, I don't think I really see it, even though I thought I did, or I didn't in the first place, and they will injure the nerve by splitting the fibers, which is what the combing is.
Okay, and an appropriate last question is about closure. What kind of materials do you use to close the opening of the craniotomy?
Oh, we used to, Dr. Janetta used to put in bone chips. I don't do that anymore.
Mm-hmm.
Then we put in titanium plates. I don't do that anymore. You can actually react to the titanium plates, or the screws that are used to put in the titanium plates as the skin thins out begin to hurt. So I use a form of bone cement in two steps. One that's firmly pressed against the bone edges so that there's no opportunity to leak fluid into what are called the mastoid air cells. They're sealed off so you don't get spinal fluid leak. And then a second layer to make it into like a little Michelangelo so it looks like nothing has ever been done. That's solid. When I finish surgery, you don't have to worry about having had a hole in your head. It's completely sealed off.
Okay. Thank you so much, Dr.
And the sutures are absorbable, so that's it. I hope we didn't take too much time.
No, we're right on time.
We got 2 minutes. One more question.
Okay. Would you tell the story of why of all the things you could have treated as a neurosurgeon, what drew you to neuropathic pain, trigeminal neuropathic pain?
I didn't get that.
You told a story once about what drew you to treating this condition.
To treat?
Yes, it was a story. You were a med student and you saw a doctor help a patient. It was so moving.
I began, my mentor, his name is Dr. Sean Mullen, who was said to have invented the balloon compression operation, was an incredibly creative man. And he came into the operating room one day and said, we're going to do this operation where we're going to squeeze the nerve. And he did it, and the patient got better. He had his reasons for doing it, and it was based on historical study. He didn't just do it haphazardly, but he didn't really know why this was working. So the next stage of my career, I got into the laboratory with animals to figure out why the heck was this working. So it was some form of innate curiosity that got me going. And the more I got going, the more people came to me for this rather odd form of treatment, which neurosurgeons didn't want to do, just the way neurosurgeons didn't want to do the microvascular decompression when Peter Janetta first invented it. They took a long time to get used to this. Balloon compression for example, is done by most neurosurgeons who treat facial pain, and 30 years ago, it was done by almost no one.
I can remember a neurosurgeon telling my mother to avoid that guy in Pittsburgh.
Oh,
It
don't avoid someone early on.
was a long time ago. It was a half a century ago, almost.
Please,
well, thank you.
Please don't avoid neurosurgeons. My suggestion is they're not dangerous. If just talk to them and see what they have to say. That's
Right.
not dangerous to talk. Thank you very much.
Things have certainly come a long way since.
They really, really have.
And you are part of the reason. And for that, I and everyone else in this community thanks you.
We'll end on that note. I like it. Thank you very much.
Okay. Take care.
We're thankful that you have joined us for our second virtual conference. When I joined FPA in November of 2019, of course, no one could have predicted that in just a few months, the world would change. COVID forced us to quickly rethink how FPA could continue to provide programs and support to everyone with facial pain. The silver lining was that because people were able to join support group meetings and these conferences and other events from the comfort of their homes, we've actually been able to serve more people than ever before. The presentations and format of this conference are a direct result of your feedback. After the conclusion of the conference, you will receive an email survey. I ask you to please help us to make these events even better by completing the survey and giving us your input. If you're not familiar with the Facial Pain Association, or you haven't had a look around recently, I would like to tell you about our services and what's been happening lately. Before I do, I also want to mention that all of FPA's resources are free and available to anyone who needs them. We want to eliminate any barriers we can so that no one affected by facial pain has to go without vital information and support. Even events like this conference and our book, Facial Pain, a 21st Century Guide, are accessible at no charge thanks to our generous donors. Last June, we launched our new website, facepain.org. The site includes reliable, accurate information about a variety of neuropathic facial pain. Our new site contains articles on topics ranging from diagnosis and treatment options to help someone who is seeking a diagnosis or is newly diagnosed to understand their condition and options, to information about mental health, research, complementary health approaches, inspirational stories, and more for people further along in their facial pain experience. The new facepain.org has so many articles, videos, past webinars, and back issues of our quarterly journal containing information on a myriad of relevant topics. We are updating these resources all the time, so remember to check back at the website frequently. We have resources for young patients, caregivers, and healthcare professionals as well. If you do not find something you need on our website, we want you to call or email us. We'll do our best to help you. Our network of support is also growing. We have a core of more than 100 wonderful volunteers who serve as support group leaders and peer mentors. You can join regional support group meetings online as well as national virtual groups. We have a family and friends group and a young patients group. As COVID allows us to, hopefully soon, many groups will start meeting back in person. But because of the popularity of our new virtual option, we expect to continue those online group meetings as well. Regina Gore, our fantastic volunteer coordinator, is going to talk more about our support programs and how you can get involved later in the conference. We also host webinars and other live events. Again, these are free and open to everyone. Members of our medical advisory board and others join us to talk about facial pain topics. If you would like to see a certain topic covered in an upcoming webinar, please let me know. One of our best resources, in my opinion, is our email bulletin that's sent out twice a month. The bulletin will let you know about upcoming FPA events and relevant events that other organizations are hosting too. If you're not currently receiving the bulletin, email us at info@tna-support.org and we will get you added to our list. This year, we launched a research initiative. To be clear, FBA does not fund research. Our goals for this new initiative are to empower people affected by facial pain to be educated partners in your healthcare and to encourage more research on facial pain and relevant issues faced by our community. To reach these goals, FPA will provide 4 resources. 1, information about upcoming clinical trials and studies and how to find them. 2, other opportunities to get involved with research. 3, articles on published studies. And 4, non-financial support for researchers. We have already worked on more than a dozen projects, and researchers have been very excited to have FPA as a resource. FPA also has a lively social media presence. If you are on Facebook, I invite you to join our group and follow our page. We're also on Instagram, LinkedIn, and Twitter. Our videos and webinars are on our YouTube channel as well. If you are a person under age 40, I highly recommend you reach out to Stephanie Blau and the Young Patients Committee to learn more about their support group, activities, and networking opportunities. If you are a parent of a child with facial pain, we can connect you with Megan Hamilton and her online group. I will end by inviting you to contact me anytime. We are here to serve you, the facial pain community. We welcome your ideas and constructive suggestions. Your involvement makes FPA stronger and more able to help more people who need it. Thank you, and I hope this conference provides you with new and helpful information and lets you know that you are not alone.